Good morning, everybody. Thanks, Astri, for this nice talk. So we'll talk on post-liver transplant management of AILD. So I'll cover on these topics outlines. So just to know, I know transplant everyone is more happy, but you should know that it is a second disease also, with a quality of life improvement only. And because it is life-saving, gives better quality of life and improved outcome. If you see, even after the best quality of life is achieved, only 50% can go to return back to the job. So that is a long-term thing when a transplant is set up. And what are the complications you can see? The first year is the most crucial part, where the mortality complications happens. And second to 5 years is the malignancy, hepatic and infections. And long-term it is the non-liver etiologies. And remember that 20% mortality only happen after 1 year. So the first is crucial, and this is all because of the surgery, quality immunosuppression, as well as the things that happened. So the complications, if you see through, so all complications, but we are focusing only on this autoimmune disease. So PBC constitutes around 10 to 50%, PSC is 8 to 44, AIH is 7 to 42. Then we should think of a transplant we have done with fear of alcohol, where a recidivist is only 10%. What about then autoimmune hepatitis? So close to half are getting a recurrence of the disease. So this is a serious thought, and that's we'll cover. So how we think of this AILD, you know. So this is the overlap of PBC, PASC and AIH. I'm not going detail. And in a transplant patient, this is another burden. You can see they are prone for rejections. You see for the T cell mediated rejections, nearly 88 in autoimmune, 33% have late onset, chronic rejection is 15%. This is a very fearsome, because we get chronic rejection in general for the transplant is close to 3%. And you can see the PBC also similar way, and also PSC. These all three goes in parallel to parallel, where you get close to chronic rejection is more than 5%, is more than the normal. So the CLD patients got transplanted, they get frequent rejections, which is more than, you can see, up to 70 to 80% of rejection at some point of time. A recurrence of disease is nearly more than 1/3, and other complications are obviously because of the disease. And PSC has a special group who have IBD with them, prone for colorectal, pancreatic cancer, and they develop osteoporosis, which is here more troublesome. So these are the things when consider this autoimmune liver disease in a transplant setting as unique and challenging. And from these, are these patients immunofragile? I think so, because we are getting so much of complications mostly related to the immunological phenomena. And if see the 10-year follow-up, survival is good, close to 70% for the patient and also for the graft. And if you see, the next comes the button is the overlap syndrome. The overlap syndrome has a more chance of recurrence, and earlier this recurrence is close to 3.39% more, 3.4 times more, and they develop in 70 to 140. That means 70 means it is close to 6 years. In 6 years, these people nearly get a recurrence, and is more with overlap than other diagnoses. And you can see here, if autoimmune PSC and autoimmune PBC, the happening in case of autoimmune hepatitis PBC overlap, it is the graft failure. This mortality is closely because of the other respiratory infection, and less is from the recurrence of the disease. And PSC have a high risk of death from graft infection, not for the graft rejection. Now I just want to highlight how these things happen in a patients of autoimmune disease. So we think this is the two groups, either they are de novo or they get the recurrent disease. So you can see here, this is a liver transplant. We got ischemia reperfusion injury. We got infections, particularly CMV, EBV, HSV, which are the systemic infections with the target also the liver. And the autoimmune milieu, either it is pre-existent or it new develops. They leads to exposure of the cryptic self-antigens, which leads to develop alloimmunity or autoimmunity to the self-antigens. So these antigens can be producing both allo or autoimmune, that's leading to the development of the disease process. So this is how it differs from the rejection. You can see rejection, it is the presence of donor MSC and metabolite antigens, which are reacted by the recipient T cells and then presented to the donor or recipient cells. Whereas autoimmunity is purely a recipient derived. You see the autoantigens has been expressed, they are being presented by the recipient T cell to the recipient OPC and leading the autoantibodies. So here in autoimmunity, the graft is at a cost because of the host. And you can see how these things happen progress. This is the T cell precursors of the bone marrow. They first go to the first level defense is the thymus. If high affinity, they get destroyed. If low affinity, they get neglected. So those having immediate affinity, they cross over, and these T cell precursors become an autoreactive T cells. These autoreactive T cells, either they develop molecular memory, most commonly the CMV EBV viruses, or they get an antigen from the liver damaged cell, and this leads to the started the perpetuation of the autoimmunity process. And at the same time, Treg cell is a regulatory, but we are giving the immunosuppression, hence this feedback is inhibited. So CNI groups have a major role, particularly IL-2 pathway, to make this process of T regulation has been reduced and leading to the more chance for developing the autoimmune phenomena. So once the autoimmune phenomenon started, how the disease causes the graft injury. You can see here, this is a recipient memory T cells which are already present in the host, and they get exposed to antigens, and they get exposed to antigen mimicries, and then this circulation cascade started, the plasma cells, cytotoxic T cells, which causes further cascade to get to the damage to the host. Whereas in de novo, there is no autoimmune milieu before, it is only the antigen mimicry, and that leads to the development of the cascade leading to the hepatocyte injury. So as you know the pathophysiology, then I would go for the individual disease. First of all, I will go to the autoimmune hepatitis. So the de novo autoimmune hepatitis is defined as indication for liver transplant is other than autoimmune hepatitis, have a graft dysfunction, excluded the other causes. Serology should have presence of autoantibodies and IgG, and have a histological characteristic of autoimmune hepatitis. And some cases we get response by augmented immunosuppression. So in that case, you can think of that is also likely, because sometimes you may not get a typical of autoimmune serology or the histology. And this is a typical of de novo autoimmunity of plasma cell interface activities. And then comes the recurrent. The recurrence is defined as liver transplant is for autoimmune. They develop characteristic histological feature. They have raised transaminases, they have raised IgG, and having the also significant titer of antibodies. So all these criteria needs to considered for a diagnosis of recurrent autoimmune hepatitis. So risk factors are the HLA-DR3 positive in the recipient, need for retransplant, chronic autoimmune hepatitis as presentation, deranged enzymes at the time of LT, pre-transplant factors, early discount of steroids in case of autoimmune liver disease. If a explant liver is showing severe inflammation or necroinflammatory activity, high pre-transplant IgG level, and now recently come up is the use of MMF. So now we have a big dilemma. If you continuing MMF, is a risk. If you stop steroids, you are getting more further risk. So this is a very unique group of patients who are at the risk. And routinely what is followed most of the centers is that these patients have a high rejection, chronic rejection, as well as the disease recurrence. So CNI remains the mainstay, despite we know that CNI causes risk aggravation. Low dose steroid has been considered the most of the centers, particularly 5 mg is continued for long term, but this endpoint has not been shown, it is all center specific. However, because of the no evidence of coming up for the steroids, ASLD suggested that we should continue stop steroid like other indications, but most of the clinicians, they continue for a longer period. And there is limited data, only 2 studies come up, good numbers definitely, 700 plus, that MMF also increases the risk of autoimmune hepatitis. So this is the largest study of 30 years follow-up from French group, but their treatment protocol is quite different. They have defined these people as long-term community steroid. If they have steroid, nearly 70% of time in their follow-up, being on some dose of the steroids, they consider protocol biopsy nearly 40% of the cases when the patient is willing to go for, and average protocol biopsy is 3.3 per patient. Majority receives triple immunosuppression based on the TAC and MMF, still they are in the more than 70%, and at 2/3 of the patients are on long-term steroid, 65% are having minimum 5 mg steroids and the long-term is going on, and follow-up is median is 87 months, but still a good number 168 months is the long-term follow-up. And you can see here the death with recurrent autoimmune hepatitis and death without this much difference. That means shows that in long term also the presence of recurrence of autoimmune hepatitis has a major impact on the outcome. So just what to and to highlight for the autoimmune hepatitis recurrence in the post transplant, it is they develop in nearly 40% of patients in close to 26 methods. They develop rapidly than the PBC and PSC. Diagnosis is challenging despite this criteria. We are not able to fulfill all the times. Pre-LT severity and the level of immunocontrol, that is IgG level high, enzymes high, are a definite risk factor for the post-transplant recurrence. Hence, we have to see these patients before when they come up. Graft loss is more than PBC. Graft loss occurs in a rapid fashion, and re-recurrence in a transplant is also very fast. So these are the, because time is limited, so these are the various studies suggesting that the AIH in a transplant setting need to consider all these points when managing this group of the patients. So the next important is what we are challenged getting, that liver transplant, the donor dilemma. We during evaluation send autoimmune markers because the relative is having a fast degree and the patient is autoimmune hepatitis. We send the test and we found that antibody is positive. How to go for? So this is the first study. Here they shown that nearly live donor setting in Canada, they shown that the titer is even positive up to 180 to 1220. But they don't found it has any significance on the outcome. And similarly, if you consider fast degree relative also, the outcome is does not much differ. So this is a food for thought. We have to see our institutional protocol also. When you think of autoimmune hepatitis to be considered with transplant, whether we should do the antibodies or no. If you do the antibodies, we again fall in the dilemma how to move ahead. And recently, I think we have one SL from ICU, the same problem has happened. So now next important component in this group is the plasma cell rejection. This is looks like autoimmune. So this has been considered a de novo AIH, post-transplant allograft hepatitis, de novo immuno. A lot of terminology are being used. It is the late onset graft dysfunction. It has overlapping features of autoimmune hepatitis. In pediatrics, it is close to 5%, little more than the adult group, and most commonly seen in the biliary atresia in long-term follow-up. In adults, is also now coming up to 2%, is more with PBC and hepatitis C virus. So the plasma cell rejection needs treatment is augmented immunosuppression, reshuffling the CNIs, and to continue steroids as the first line therapy. Second line is limited, that is plasma exchange or immunoglobulins. Third line to consider rituximab or proteasome inhibitor bortezomib, thinking that it is a autoimmune related, mostly antibody mediated reactions. And pathogenesis, some role is by the calcineurin, viral infections. Hep C is the most of the studies shown to have, and this occurrence of rejection prior, and those having DSA, this donor specific antibodies may be contributing to this group of the patients. So plasma cell research, this is a study where the 35 patient series, because we have not got much data, but here the 40% develops plasma cell resection and 68% progress to cirrhosis, and this is nearly half of them to be hepatitis C, and they have DSA positive in 16 out of 19 who has been tested, and C4D is positive 9 out of 10 tested. So this is, we should consider particularly hep C patient long term having persistently transaminitis, whether these are the groups or no. So you can see here the plasma cells at various points has been stained here, and the criteria is that portal or perivenular plasma cell more than 30% infiltrates lymphocytic cholangitis. Original disease is not an autoimmune hepatitis, and we need to consider these patients as plasma cell. This has been considered by the Banff schema they developed. So this is a pathological slide, but just know why we get plasma cells in a liver biopsy. Though the plasma cell hepatitis is seen in few. De novo AIH as we have discussed. Acute cell rejection we may get little bit, and a recurrent hepatitis C. So hepatitis C, either it is positive or it is silent, like plasma cell hepatitis or de novo AIH is a major mimicker for post-transplant patients to have a plasma cell rejection. This so it's very interesting. Now it is come up that in addition to the plasma cells, IgG4. So what they have shown, these patients is grouped as plasma cell hepatitis in the biopsy. If it is non-transplant, they should be treated like an autoimmune hepatitis. If IgG4 staining is positive in post-transplant, if he is having pre-transplant AIH, then likely it is the recurrence of the AIH. Or if it is not having diagnosis of pre-transplant as autoimmune, then it may be plasma cell rejection. The plasma cell resections are important 2 points, the response to treatment with immunosuppression augmentation is better than the autoimmune hepatitis rejections. So this is a good point what we should think of. Just to summarize the post-transplant AIS recurrence, we need to identify validate early biomarkers for recurrent autoimmune hepatitis. We need a RCT for the low dose maintenance versus withdrawal to see how they are happening. Plasma cell rich rejection and plasma rich AIS, we need to differentiate that outcome, follow-up and histopathology. Implication of DSA in long term, as we are getting now most patients of transplant up to 1 year the DNS LFTs, how this DSA is implication role for autoimmune recurrence or plasma cell hepatitis, and LDLD scenario donor selection outcome and perspectives from as autoimmune hepatitis also needs to be debated. So next coming to is the PSC. I can show here the diagram, you can see here. So this is a post-transplant patient, this is a post-transplant patient, you can see, and this diagram, I think it is recurrent of PSC. So this is different from the stricture which is a focal, and you can see here this is a diffuse stricturing which is called as ITBL ischemic biliary lesions. So when a person comes with us, either they have this pattern of a PSC recurrence or a stricture is a variant called ischemic biliary lesions. So how to diagnose PSC after the transplant? The liver transplant is for the PSC. Cholangiography showing non-anatomic strictures. The absence of other causes, particularly ABO incompatible, non-stricture, thrombosis, rejection has been excluded. And liver biopsy may be helpful, but it is not mandatory, but at least 3 of these criteria should be fulfilled. And the pathogens for this pre-transplant is the gut microbiota, presence of IBD, genetic predisposition, and those having severe PSC before the transplant are candidate to develop recurrent PSC. Frequent acute cellular rejections, post-transplant CMV infections, and few of the donor characteristics we are coming now are the risk for this group of patients. So chronic rejection mimics PSC as we have discussed. The strictures will be only visible in imaging. Biopsy is having the ductopenia which is not there in recurrent PSC. The only characteristic is ductopenia is absent. And you can see here the risk factors as far as IBD is considered, the presence of colectomy.
Previous slide.
Yeah.
This is an important slide. Just differentiate the two.
Yeah. So in chronic rejection, we may get yearly, and it takes long time. ALP, GGT are only rising, but in chronic rejection, clinically you get frequent history of rejections, multiple episode or not resolving rejections, and history may be defaulter or immunosuppression. That's a clinical history wise. Then if biopsy can sign portal changes, particularly is no significant expansion, biliary epithelial cells and mostly duct loss will be there. The florid duct loss will be there. Whereas recurrent PSC, the portal changes will be mixed infiltration. There is periductal edema, pericholangitis, focal biliary degenerative changes. Mostly the changes confined to the biliary system, but without having the ductopenia. And interface changes you may not, obviously not to get in chronic rejection, or minimal maybe in early chronic rejection, not in the late or established chronic rejection. But you can get these interface changes in case of chronic, in case of recurrent of PSC. Cholestasis you find in because of the ductopenia will get there, but in case of PSC it may be variable if presence of jaundice is there or no. Fibrosis will be less, however fibrosis will be more frequent in case of recurrent PSC. So this is the study taken from multiple studies which shows that IBD, presence of a colon is a risk. Steroid use for long term has no data. So presence of IBD or presence of a colon after transplant is one of the risk factor. Use of OKD3, development of steroid resistant rejections or acute rejections. Donor recipient mismatch, particularly HLA-DR B1, first degree relative donors, and CMV mismatch and CMV titer infections. The CMV mismatch means D and R status. Organ if it is having a elderly donors, and severity of PSC, having a high MELD score of the PSC patients. These are the groups who are likely to have a chance of recurrence of PSC of the transplant. So just to summarize big list, the most important are the presence of IBD, colon in situ, cholangiocarcinoma prior to transplant, having at least 2 or more episodes of rejections before, advanced donor age, male gender in a younger age, they are prone to develop recurrent PSC, and we have also 3 to 4 here. And this is such a severe disease but having good survival, in that these patients have, you can see the last series, they shown the transplant has happened for 4 times. This is the data from the ELIDA, where they have gone for the transplant, make this patient survivable for a long term. So just to summarize, what are the practice points? PSC happens nearly 1/3 of the patients in a median period of 4 to 5 years. Risk factor of PSC is quite heterogeneous. However, PSC with IBD considered transplant should be special. They need a personalized protocol care, as we have discussed. For the colectomy, yes, no, that is still debate on this. And the graft loss is highest after PSC than any other autoimmune disease, and the retransplant is very frequent, as we have seen in the previous slides. And data on survival is conflicting, but graft survival is definitely less, but it is okay with some comorbidities. So in the PSC in a transplant setting, we need the data on multicentering, how the pre, peri and post-transplant variables, donor-related factors can be considered to predict for the recurrence of PSC, to identify high-risk individuals for a customized therapeutic intervention in the post-transplant setting. Healthcare cost and the retransplant, where and how to go for, that is a big challenge. And interplay of the IBD and PSC, gut liver axis modulation with probiotics or other therapies, whether we should consider from the beginning in a patient who is going for the follow-ups, and immunosuppression protocol also, as we have discussed. So these are the few areas which needs to be addressed. All data is there, but is patchy. So this is the research area you can say in this area. Then the third is the PBC. If you consider PBC, the diagnosis liver transplant for the PBC, they have a histological finding, that means biopsy is a must, presence of AMA and elevated IgM level, and does exclusion of other causes. The probable is all the 3 criteria, and definitely is having the 4 criteria. So this is for the diagnosis of the PBC after the recurrence transplant. So most common risk factors for PBC are younger age for the diagnosis of PBC and going for the LT particularly before 40. Tacrolimus has been studied in various studies to be a risk factor for developing PBC recurrence, so that we have to think of. Gender mismatch, high IgM level before transplant, and if persistently raised enzyme in a patient of a PBC, and cholestatic, if they develop a cholestatic liver function in first 6 months, they are likely to develop a recurrence of PBC. And very interesting study, the studies in 2003 shows that cyclosporine and tacrolimus, cyclosporine is little bit helpful, whereas tacrolimus causes increased risks of developing early recurrence of PBC. And this study has moved forward. They found a GWAS, the RS622704 and CNI. This shows that if a person is having cyclosporine, they have a phenotype of AA, then they have a less chance of recurrence of PBC than cyclosporine with AG phenotype. Whereas if you are giving tacrolimus with AA phenotype, they are of the highest risk. So if a PBC patient with us, and we have to decide whether to go for cyclosporine or tacrolimus, and if you are going for the tacrolimus, if possible you can get this GWS that can help. So in absence of this, we can think of, to me, 6 months to 1 year as tacrolimus, then obviously we can think of changing to cyclosporine for this group of patients to get help. And just to summarize for the how I change my practice with the PBC, PBC is close to 10 to 42% develop recurrence, but little late, around 46 months at 4 years. We need to think of this data, HLA mismatch or CNI type, but obviously it is individualized with presence of some studies of favor. And recurrent PBC has the lowest risk graft loss of all the groups, and UDCA has been shown to prevent recurrence. So now UDCA for all post-transplant PBC is considered more than most of the practice and most of the studies, and hopefully we can use this to improve the survival. Just now, as we discuss the recurrence, what should be my strategy to go for? So first is the discuss the immunosuppression adjustment is one of the good art, particularly steroid is definitely there. Azathioprine or MF should continue with inhibitors CNIs. If still enzymes are there, then we should continue both CNI and steroids. We can think of azathioprine. The old age drug still holds good, particularly autoimmune group of patients, and we have also a couple of patients to consume the azathioprines. And if still is not getting better, in that case we have to think of switching to the CNIs, particularly from tacrolimus to CNI groups, and can consider sirolimus or everolimus. So this is one of the things when you're dealing a patient of autoimmune recurrence with persistent transaminitis, and that we think of. Then strategy 2 is to identify the risk groups. So as we have done patient factors, transplant factors, post-transplant factors. So as we have discussed already, so I'm not going detail, but these are the factors we have to look into. Then each patient of the autoimmune hepatitis before going for the transplant, we have to make a checklist of the high risk. We have to make a stratification strategy, and how the immunosuppression plan, monitoring plan should be there is a must. And third, a customized care. The customized pre-transplant autoimmune hepatitis, as we have seen, that high level of IgG and high level of AST/ALT or biopsy having necroinflamed activity is a strong risk factor for recurrence. So we should see that when these patients are stable to go for, but I could not find how to reduce the IgG in a case of autoimmune hepatitis. But obviously, I think autoimmune hepatitis, good control should be considered yearly. And immunosuppression, about the steroid low dose, mostly we are using. So whether it should be approached by the tender, that it should be a must, that we have to decide. But in large French study, they are continuing for a long term, at least 5 mg. So I think this is a good idea to consider. If a PBC, whatever literature I have reviewed, and I think use of UDCA is a cost effective treatment, so we should think of in a PBC. And if possible, tacrolimus cyclosporin can be considered. If not at the yearly, maybe at least 6 months to 1 year of the post transplant can think of. PSC, we need to control the IBD definitely before the transplant. The colectomy should be considered or no, that needs a discussion in a multidisciplinary board. And we need to maintain the IBD at remission throughout the transplant period. And if it is IBD getting any symptoms, it is better to go for colectomy, so that the PSA recurrence as well as the IBD component can be handled in bigger way. So just to summarize my slides, if a post-transplant patient comes to you, the risk of recurrence and challenges are more highest with the overlap than PSC, and then is autoimmune hepatitis and the PBC. Thank you.